Hi, my name is Scott Simpson, and today we're going to be talking about smooth interlobular septal thickening. So when we talk about septal thickening, we're talking about thickening of a particular interstitium within the lung. So what are the different interstitiums in the lung? The different interstitiums in the lung are the peribronchial vascular interstitium. This emanates from the hilum into the lung parenchyma and is in continuity with your centrolobular interstitium. The other major interstitium is your subpleural interstitium. This grows out from the lung edges into the lung parenchyma to give you your interlobular septa and your intralobular interstitium. So these are the 5 major interstitiums within the lung parenchyma. When we're talking about the interlobular interstitium, this is what separates out these secondary pulmonary lobules, which is the major architectural unit of the lung. And this is what we see on the right here. The secondary pulmonary lobule, in the center of it, will have your pulmonary artery, and will have your airway. And in the periphery, you'll have your lymphatics, you'll have your veins, as well as this collagen network that gives you your interlobular septa. Your interlobular septa provides the outline of each of the secondary pulmonary lobules. It separates each of the secondary pulmonary lobules from one another. So this is the interlobular septum. When we're talking about smooth or nodular septal thickening or septal thickening, we're talking about thickening of the interlobular septa. Okay, that's what we're talking about here, the division between the secondary pulmonary lobules. Now there's also something called the primary pulmonary lobule, which the secondary pulmonary lobule is composed of, and what separates each of those is the intralobular septum. But again, when we're referring to septal thickening, we're generally referring to the interlobular septum, the septum that surrounds the secondary pulmonary lobule. So what is the appearance of septal thickening? That is, thickening of the interlobular septum. This could either be smooth, nodular, or coarse or irregular. So let's talk about smooth interlobular septal thickening. This is a CT in lung axial window settings, and we could see that there's these lines within the lung. So these lines within the lung. These long lines within the lung represent areas of interlobular septal thickening. And we could see how these lines can outline the edges of a secondary pulmonary lobule. You could see that in the center of the secondary pulmonary lobule, this dot is the artery that we had just talked about. And we can see how the edges now are being outlined by interlobular septal thickening. The septum is thickened that surrounds the secondary pulmonary lobule. Here again is another example of smooth interlobular septal thickening. We see these lines within the lung now running in between the bronchovascular anatomy. And we can also see out here thickening of a secondary pulmonary lobule given this polygonal shaped structure on the periphery of the lung with a small artery in the center of it. The reason why I like this case is that just like the interlobular septa being an interstitium, we could also see that there's thickening of the bronchovascular interstitium, and this will manifest as areas of bronchial wall thickening. So you could also see that there's thickening of the bronchovascular interstitium, and this makes sense because if you have thickening of one interstitium, you may have thickening of another. So as an example both of smooth interlobular septal thickening as well as bronchovascular interstitial thickening manifesting as bronchial wall thickening. So how about on chest x-ray? What does smooth septal thickening look like on chest x-ray? So it's going to look fairly similar to what we see on CT, albeit a little bit more difficult to see. And this will give you short little lines, typically in the lung periphery out here. And these are what are known as curly lines, and we'll have more discussion on this in a couple of slides. These can be fairly hard to see initially, so if you kind of zoom in, again, I hope you could see that there's these short choppy lines out in the lung periphery representing curly lines, and that's these kind of stair-stepped appearance out in the lung periphery. These are all curly lines, and curly lines represent areas of smooth interlobular septal thickening. How about nodular septal thickening? So nodular septal thickening, again, we're going to see areas of smooth septal thickening, but they often appear beaded. They give you a beaded appearance. So again, we can see that there are these lines within the lung, When we look at the lines, we note that there's like little small beads within them. So little small beads within them. They're not just very smooth, they just have this beaded appearance. And this beaded appearance is what we say is nodular septal thickening. Here's a Another example of nodular septal thickening on CT. So the arrows are pointing to a secondary pulmonary lobule, which is being outlined by septal thickening. In the center, we could again make out the pulmonary artery. And then in the periphery, though, we note that there's this small beaded appearance, in addition to the septal thickening that's running through it. This again is an example of nodular septal thickening. Lastly, we have coarse or regular septal thickening. So instead of the lines in the lung being very smooth, they often appear shaggy. Instead of being straight, they're often bizarrely or corkscrew in shape. So in this CT, we can see that on the periphery of the lung, though again we have all these little lines, except they're not as well defined as we saw for smooth septal thickening. They appear somewhat irregular on the edges, and then they don't really look straight. They almost have a corkscrew-like appearance to them. And this is an example of coarse or irregular septal thickening. Here's another example, again, where we can see all these lines out on the lung periphery. In addition, we could see some areas of honeycombing. These are these cystic spaces, as well as areas of traction bronchioloectasis, these dilated peripheral airways out on the lung periphery. The reason why we see these associated findings is that coarse intralobular septal thickening is often a manifestation of fibrotic lung diseases. Another name for coarse or irregular septal thickening in association with intralobular septal thickening is reticulation. And again, that's something that we typically attribute to fibrotic interstitial lung diseases. We'll spend greater time discussing this topic in a fibrotic lung disease lecture. Okay, so now that we have a framework here of the different interstitiums within the lung, the different appearances of septal thickening, let's now talk about the main topic, which is smooth septal thickening. I typically attribute this to three major causes, so interstitial edema or fluid within the lungs, some sort of lymphatic process within the lungs, so typically lymphatic distension, and again, remember on the edges of the secondary pulmonary lobule is where you see a lot of the lymphatics, as well as some infiltrative disorders. So interstitial edema, so fluid within the interstitium of the lung, this is typically hydrostatic and it can either be related to some sort of cardiac process or a venous obstructive process. The big causes there being acute congestive heart failure, as well as some causes of venous stenosis. So we see venous stenosis in the setting of lung transplant, atrial fibrillation ablation, fibrosing mediastinitis. Fibrosing mediastinitis, you could think about histoplasmosis as one of the more common causes, as well as a rare disorder known as peripheral veno-occlusive disease that produces pulmonary hypertension. Lymphatic distension, on the other hand, is generally rare. We can see this with some disorders known as lymphangiectasis and lymphangiomatosis. We'll discuss these very briefly. And then some infiltrative disorders, so cells infiltrating into the lung. The biggest one here being lymphangitic tumor, as well as some congenital disorders. So what can produce lymphangitic tumor? This can be the result of a carcinoma that's spreading along the lymphatics. We call that lymphangitic carcinomatosis. We could also see it with leukemia and lymphoma. Some infiltrative disorders related to the histiocytic spectrum include Erdheim-Chester disease, and we could also see NiemannPick's disease, which is another congenital disorder related to glycogen storage. But of all the causes that are listed up here, the big ones that you guys really want to take away are lymphangitic carcinomatosis, as well as some sort of pulmonary edema. So let's talk about pulmonary edema on chest x-ray. So pulmonary edema on chest x-ray is usually in the setting of hydrostatic or cardiogenic pulmonary edema. So on chest x-ray, you'll see some associated findings. These associated findings are often the presence of cardiomegaly. So you can see here the heart is greater than 50% the width of the transverse dimension of the chest. We also note that this patient has a pacemaker in, again, alluding to the fact that the patient has a cardiac abnormality. And in the lung periphery, we already had briefly touched on this. We can see the presence of these short, choppy lines. These are known as curly B lines. So curly B lines. So these are known as curly B lines. We also see some longer lines emanating from the hilum. These are what are known as curly A lines. Curly A and curly B lines are both the result of intralobular septal thickening. This appears smooth. There's also something known as curly C lines, where you get this lace-like network of overlapping lines, typically in the lower lung zones. Again, just another manifestation of smooth intralobular septal thickening. Other associated findings of cardiogenic pulmonary edema may include pleural effusions, where you may see some blunting of the costophrenic angles, representing fluid accumulation in the pleural space. Here's a CT representation of that same patient. We're partially visualizing the enlarged heart here. We could also see the smooth interlobular septal thickening. This is typically worse in the lower lung zones for cardiogenic pulmonary edema. It's typically worse in the lower lung zones. In association, you can see that there are some ground glass opacities here. This typically reflects alveolar edema. So in this case, we have both interstitial as well as alveolar edema in the setting of acute congestive heart failure. We could also see interstitial edema in the setting of venous obstruction. So here's another case where we could see that there is areas of smooth septal thickening. You also note that the veins out in the periphery of the lung are pretty distended here, kind of owing to the fact that there's hydrostatic edema. We could also see that there's a unilateral pleural effusion. So could this be congestive heart failure? Possibly. The heart does look somewhat prominent here. It's unilateral, which we don't uncommonly see in the setting of unilateral pulmonary edema in the setting of congestive heart failure. But the big clue here, the cause for this pulmonary edema, is actually the veins. The veins are all occluded centrally. You can see that they're completely cut off from the left atrium in here. There's no venous filling centrally there. They're all occluded. And this was the result of a venous stenosis following pulmonary vein ablation for the therapy of atrial fibrillation. The treatment for atrial fibrillation, one of the treatments for it, is that they can go into the left atrium and then ablate different foci within the left atrium to try to isolate the ectopic focus that's causing the atrial fibrillation. One of the areas that they try to ablate is around the orifices of the pulmonary veins. Because you're ablating around the orifice of the pulmonary vein, that can lead to fibrosis, stenosis, and potentially occlusion. The veins are then occluded, they have no drainage back to the heart. That leads to lots of hydrostatic edema within the lung, producing your septal thickening, pleural effusions, and bronchovascular thickening that we also see here. It's another interstitium that is thickened. So this is an example of unilateral edema following atrial fibrillation ablation. Here's the 3D volume rendered image following a CT venogram. So here we can make out the pulmonary artery, and the pulmonary artery is in here. And then we could also make out the pulmonary veins on the left side, which are over here, draining into the left atrium. But note there's absence of pulmonary veins on the right, and that's because they're stenotic and occluded, no longer filling, resulting in that appearance of unilateral pulmonary edema. Another cause of venous obstruction that's much rarer and is a cause of pulmonary hypertension is something known as pulmonary veno-occlusive disease, also known as PVOD. PVOD is the cause of pulmonary hypertension, in which case the pathology relates to the obstruction of venules throughout the lungs. Because the venules are obstructed, this can result in the accumulation of pleural fluid within the interstitium because blood can't move forward and fluid is going to transudate out into the lung. Therefore, we're going to develop areas of smooth septal thickening that we can see in this image up here and this image over here. Again, we can make out these areas of smooth septal thickening. In addition, we could also see regional areas of mosaic perfusion in the lung, that is areas of vascular oligemia, these areas that look too hyperlucent. There's a separate lecture that discusses the approach to mosaic perfusion. I could refer you to that for better discussion and a more in-depth view on mosaic perfusion. And then the two additional findings that we see in the setting of PVOD is a dilated pulmonary artery, and that's because the patients will have pulmonary hypertension. All the venules are obstructed. The heart is having a really hard time pumping blood through the lungs, resulting in pulmonary hypertension and a dilated pulmonary artery. In this case, we could see the pulmonary artery is greater than 1-to-1 with the aorta. In addition, we also develop these waterlogged lymph nodes. They also develop mediastinal and hilar lymphadenopathy. And that's because these lymph nodes become hyperplastic because the lung is chronically filled with edema and the lymph nodes are all kind of draining that, so they become enlarged with time. So you get a classic triad. So what is the classic triad? The classic triad is you're going to develop septal thickening within the lungs, you're going to develop pulmonary hypertension, so a dilated main pulmonary artery, and then the third being lymphadenopathy. Septal thickening, dilated pulmonary artery, lymphadenopathy. One cause you can consider here is something known as peripheral veno-occlusive disease, PVOD. Another clinical clue that the patient has peripheral veno-occlusive disease is that they have pulmonary hypertension, and when then placed on pulmonary arterial dilators, they decompensate. And the reason for that makes sense. If you dilate all the arteries against obstructed venules, the fluid and blood has nowhere to go, so it produces pulmonary edema, and that's what we see here. We have someone that's relatively normal on the CT on top. They were then placed on a pulmonary arterial dilator and developed pulmonary edema. On CT, this is manifesting as areas of ground glass opacity, as well as pleural effusions. So it's an example of PVOD with decompensation following pulmonary arterial dilation. Okay, this is a common clinical scenario. That's a really good clue that you're looking at PVOD. So let's move on to lymphatic distension. So the causes of lymphatic distension are generally pretty rare. So there's some congenital causes like lymphangiomatosis and lymphangiectasia. Lymphangiectasia we never see in adulthood. This is something that's diagnosed perinatally. Pulmonary lymphangiomatosis we can see into children and young adults because of hormonal stimulation. Even though it's a congenital disorder, you'd expect it to be present at birth. It may not actually produce symptoms until adulthood or adolescence. It has to do with hormonal stimulation. But you could also develop secondary pulmonary lymphangiomatosis. And this happens in people that have injuries to their thoracic lymphatic system, so like thoracic duct injuries following trauma or surgery. And this is what we're seeing here. We again have areas of septal thickening within the lungs. You can see outlines of the secondary pulmonary lobules within the lung parenchyma. We also have a pleural effusion. These findings are nonspecific, but what really gives us away is that the pleural effusion was chylous. It actually had lymphatic fluid within the pleural collection. So perhaps then we're looking at pulmonary lymphangiomatosis. Another big clue in this case was the appearance of the mediastinum. The mediastinum had all these what looked like masses extending out into the hilum, but this actually measured fluid attenuation. And these actually represented large lymphoceles, large collections of lymphatic fluid within the mediastinum. This is an example of secondary lymphangiomatosis from a thoracic duct injury. So there's really, again, nothing specific about this case, except that this patient has these cystic lesions within their mediastinum and the fluid that came out of their pleura was chylous. You want to think about chylous pleural effusions in the setting of some sort of lymphatic disorder. In adults, this is usually secondary, some sort of thoracic duct injury. Now moving on to infiltrative disorders. So the biggest infiltrative disorder here is tumor, lymphangitic tumor. When the lymphangitic tumor is the result of, say, like a solid cancer like lung cancer or breast cancer, we call that lymphangitic carcinomatosis. So on chest x-ray, we again note that there's septal thickening on the lung edges. These are curly B lines. Curly B lines just mean intralobular septal thickening. It's not specific for pulmonary edema, although we typically attribute to that. It's not specific for it. It just means that there's septal thickening. So we can see that there's septal thickening out in the lung periphery, manifesting as curly B lines. However, we note that this is unilateral. It's really just affecting the right lung. In addition, the left lung is relatively small. We can see that there's elevation of the left hemidiaphragm. It's relatively hyperlucent, and we also note that there's some clips in here. The clips are from a lobectomy, and that's why the lung volume over here is small and slightly hyperexpanded. This is a person that had a lobectomy from lung cancer. The lung cancer had recurred, producing unilateral septal thickening and lymphangitic carcinomatosis. Here's an example of a CT of lymphangitic carcinomatosis. There's really not much specific here on the CT. We can see again that there's areas of smooth septal thickening. There's a little bit of bronchovascular thickening. Again, that's another interstitium that can be thickened. Again, there's just interstitial thickening. So this case is intralobular and bronchovascular interstitial thickening. This is a case again of it being unilateral, so unilateral disease. And one of the things that we consider there would again be lymphangitic tumor. Hopefully we'd have a history of a previous breast cancer or lung cancer or something along those lines. Now as a sidebar, lymphangitic tumor can also be nodular, and that makes sense, right? There's tumor accumulation. We think of tumor as being nodules and masses, and that can happen. So we can see here that there's areas of a beaded appearance of the septum. So lymphangitic tumor can produce both smooth and nodular septal thickening. Often when it first starts out, it just is smooth, and as it progresses, it can become more and more nodular. But it's good to keep in mind that lymphangitic tumor is both smooth and nodular. And this is an example of nodular septal thickening related to lymphangitic tumor. Now there are some congenital conditions that can produce smooth septal thickening. One of the ones that is frequently mentioned but very uncommonly seen is something known as Erdheim-Chester disease. Erdheim-Chester disease is a histiocytic disorder, but it's a non-Langerhans cell histiocytic disorder. So it's a histiocytic accumulation within different parts of the body. The most common organs that are affected are the lungs. So in the lungs here, we can see that there are areas of septal thickening. In addition, there's some cystic change, another manifestation of this disease. The tip here is that you're basically seeing disease elsewhere. You're seeing that there is this encasement of the kidneys with this ill-defined soft tissue. So you see all this encasement in here. We see that there are sclerotic bone lesions, often throughout the skeleton. And then we could also see that there's an infiltrative process within the retrobulbar region, so just behind the eyes. This is an example of Erdheim-Chester disease. On CT, it can be a very confusing appearance. It is reported to produce smooth septal thickening, but there's often other manifestations elsewhere. There's stuff in the bones, there's stuff surrounding your viscera. And then lastly, another common congenital disorder that can produce smooth septal thickening, or commonly reported to produce septal thickening, are glycogen storage diseases, particularly Niemann-Pick disease. So Niemann-Pick disease, glycogen storage disease, producing just widespread septal thickening. This is an example of that. Not much, again, specific here. We see that there is just diffuse septal thickening throughout the lung. The heart's normal in size. There's no pleural effusions. One thing that you could consider here is Niemann-Pick disease. So what is our approach to septal thickening? So the most common causes by far when you see septal thickening is interstitial pulmonary edema and lymphangitic tumor. When someone asks you what is your differential, those should be the first two that you start with. So pulmonary edema and lymphangitic tumor. Other causes are peripheral veno-occlusive disease, some congenital or secondary lymphatic disorders, as well as some very rare conditions such as Erdheim-Chester disease and Niemann-Pick. But the big two that you want to start with up here are interstitial edema and lymphangitic tumor. So what is our approach? So if it looks fairly symmetric, so you have fairly symmetric septal thickening on chest x-ray or on CT, the big thing that you want to consider here is pulmonary edema. This is typically hydrostatic, related to acute congestive heart failure. If it's unilateral, you want to consider also cardiogenic edema because it's so common, this can happen. But you also want to consider the possibility of lymphangitic carcinomatosis or something wrong with the veins on one side, so venous stenosis or occlusion from pulmonary ablation or fibrosing mediastinitis. You also want to look for associated findings. So if there's cardiomegaly, perhaps you're looking at acute congestive heart failure. If there's ipsilateral hilar enlargement, either on chest x-ray or on CT with lymphadenopathy, you want to consider the possibility of lymphangitic carcinomatosis. If you see fluid attenuating lesions in the mediastinum or there's chylous pleural effusions reported in the patient's chart, you want to consider a primary or secondary lymphatic disorder. If you see diffuse disease elsewhere in the body, so you see perirenal soft tissue, multiple sclerotic bone lesions, perhaps you're looking at a very rare disorder of Erdheim-Chester disease. If there's pulmonary hypertension, lymphadenopathy, a dilated main PA, septal thickening in the lung, the classic triad of pulmonary veno-occlusive disease. So that's it. That concludes our septal thickening talk. This was about smooth septal thickening. If you have any questions, please feel free to reach me via email. Thank you.